So I would like to talk with you about the following topic: clinical diagnosis of rare EDS without a genetic cause. What next? Let me see. Yeah. So just a quick overview. I'll do a short introduction, and there will be 2 case examples from clinical practice that I will discuss, and then I'll arrive at conclusions. Of course, we are talking today about clinically and genetically defined EDS types, and here already are a few features that you can often encounter in people with different rare types of EDS. Very stretchy skin, for example, on the left side, recurrent dislocations leading to deformations of fingers and thumbs. It's sort of very easy bruising at unexpected locations in a young child, a young girl with a scoliosis, abnormal atrophic scarring, and sort of generalized lack of attached gingiva, as can be seen in periodontal EDS, and is really pathognomonic for that condition. So that is helpful for us as clinicians to know. Also, it's always good to keep in mind when talking about EDS and the different EDS types, that the prevalence of monogenic EDS types, they're not for nothing called rare, ranges from 1 out of 20,000 to 1 out of 90,000 for the dominant types, to less than 1 out of 1 million for the recessive ones. So major and minor clinical criteria for each monogenic EDS type have been defined in the 2017 paper, which is really helpful for everybody, I would say. And also the background of this talk is that at the moment in the UK we have the EDS exome gene panel, which covers 47 genes. And this includes, of course, the genetic causes of the rare types of EDS, but also conditions that have overlapping clinical features, such as cutis laxa and Lewis-Dietz syndromes. So it's quite a good panel in that regard. So first example, a clinical diagnosis of a rare EDS type, but no genetic cause. So just as a quick overview, this is a negative EDS gene panel test result, as we get it in the post or by email anno 2023. And it's important to look at sort of the implication. It says when sort of no abnormalities have been identified, this testing excludes more than 99% of reported pathogenic variants in the genes tested, but also has the disclaimer, this result does not completely exclude a genetic diagnosis. So I had such a result, although sort of the genetic testing that was done was earlier on, before this very new panel. And this concerned Alice, who, in our opinion, definitely had a diagnosis of classical EDS with atrophic scarring, hyperextensible skin, generalized joint hypermobility. But there was no genetic cause identified with the classical EDS gene panel then. So that would only have sort of covered the COL5A1, COL5A2, and the COL1A1 gene. And there was only MLPA of the COL5A1 gene. So what we did, because it was available to us then, was trio whole exome sequencing, which did not show abnormalities either. That was difficult because, of course, the question of the parents of the patient was, wow, why is the genetic testing normal? Is it really classical EDS? Are there maybe more significant complications to be expected? What is the outlook for my daughter? So the question was, why is this genetic test negative? So of course it could be that there are coding SNVs or indels in known disease genes that are not in the panel that was applied. There can also be the option of non-coding variants. There can be the option of structural variants. And of course it can always concern a new disease gene discovery. So these are always possibilities to keep in mind. What are potential next steps? So trio whole genome sequencing is a potentially next step, but of course we already mentioned that it's not diagnostically widely available yet. RNA sequencing is often sort of in a possibility mentioned as well. Quickly sort of going to mention that Alice and her parents were recruited to the 100,000 Genomes Project, which was a research project run by Genomics England. And they recently published in a New England Journal of Medicine sort of pilot data where they commented on 2,183 individuals. And they mentioned, and that's where the error is, that 25 of the probands received a genetic diagnosis. And then I thought immediately, well, what happened to the other 75%? I mean, that's not that's a question mark. Well, maybe there are various reasons. So maybe it wasn't a monogenic condition, which that's of course maybe the wrong panel was applied because not all clinical features were present, concerned a young child. Maybe indeed some genetic causes have been missed. So with regard to Alice and her result from the 100,000 genome sequencing project is that there were no primary findings, as it was mentioned. So her result was again normal. And it did mention that data would continue to be analyzed in the research environment, which is a specific environment where sort of the genetic data of the patients recruited to the project will be able to be accessed by researchers who have signed up to specific projects in the research environment. And that is really helpful to know because several years later, I was planning to do a skin biopsy in this girl to perform RNA sequencing because I still was convinced that it was classical EDS and it might give us some clues that there would be haploinsufficiency of, for example, collagen COL5A1. And they cancelled at the day, and very sort of fortunately, there came a clinical collaboration request from a researcher who had been analyzing the genomic data in the research environment of GIL and said, actually, I've used a program called SV-RARE to detect disease-causing structural variants in the 100K genome project, and I've detected a pathogenic de novo exonic deletion in COL5A2 containing a small internal segment that was inverted. So this was confirmed on the already existing whole exome sequencing data, and there was a diagnosis of a genetically confirmed diagnosis, which gave the parents and also the patients a lot of relief, because finally it was clear that it was indeed classical EDS, and they had a better idea about what the issues would be. So another scenario is where we have not a clinical diagnosis, but we have a clinical suspicion on a rare EDS type. So that's a bit different. And in this case, there was a variant of unknown significance detected. It concerned an individual with an ischemic stroke, and he had a left internal carotid artery dissection, and also multiple medium-sized arterial aneurysms and stenosis were detected at the age of 58 years without known risk factors. There were, and it's important, no other clinical features pointing, for example, to vascular EDS. Of course, it is something that you can see in people with vascular EDS, but you can also see it in other monogenic conditions. So a colleague of mine had already done genetic testing for the then vascular EDS gene panel, which would only sort of include the COL3A1 gene and the COL1A1 gene, and had identified a VUS, sort of a deep intronic genetic change. I subsequently did also a aortopathy gene panel to be sure that we are not sort of missing any other more clear sort of likely pathogenic or pathogenic variants in other genes. That was normal. So of course we ran through the COL3A1 VUS elaborately, detected at a low frequency, reported by 2 other laboratories in a patient with EDS, not specified, very unhelpful, always important to specify the EDS type. One patient with FTAA, and it was also reported in one patient with an abdominal aortic aneurysm in the literature. There were also the use of in silico prediction tools, and we've heard about this already in the morning session. And it was predicted that this variant may disrupt the splice acceptor site of exon 13 and create a cryptic splice site in intron 12. So what was needed at this point was really well-established in vitro or in vivo functional studies supportive of a damaging effect on the gene or the gene project. And of course, we didn't have that. So again, next step in this case was really RNA sequencing. So we took a skin biopsy for RNA sequencing to assess sort of potential impact on gene splicing. So NGS sequencing of mRNA extracted from fibroblasts has been carried out, and it's important because, of course, the expression of the collagens is better in fibroblasts than in blood. So that's an important point to take into account. And recently, hot from the needle, we received an interim result that there might be leaky splicing present with 2 non-consensus 3 splice sites being not utilized 100% of the time. And so there is evidence that this VUS may disrupt splicing, but to what extent is currently being investigated. So further work is underway to sort of accurately quantify the aberrant splicing, because that's important. And I'm suspicious of this variant also because the phenotype, it is that this variant might cause it just a little bit milder, well, you wouldn't say milder with all these complications as 58, but still a bit later in life complication than most people with vascular EDS, for example, would have. Anyway, arriving at the conclusions. So I think that an expert clinical assessment is of the utmost importance to determine which individuals with a normal genetic test would require further workup. I think this is what we are really suitable for, definitely clinical geneticists, but any sort of expert who knows the clinical features of a rare condition really well is very suitable for that. And then, of course, whole genome sequencing and RNA sequencing can help identify genetic causes, but we need to be realistic because these methods currently have a long turnaround time. I haven't mentioned the timelines, but for the first case that lasted from 2016 to 2023 before we had a diagnosis. And also the workup is obviously very bespoke because it depends on the specific genetic change identified. If it's a VUS, it depends on the specific gene sort of that is suspected to potentially be the cause. So it's not easy. And also to keep in mind really that it is still the case that a large majority of clinical diagnosis of a rare EDS type will be confirmed through a good EDS gene panel testing, and is in that way, if the patients are seen clinically and they have had a genetic test and there was already not a high index of suspicion from the clinical examination, the test result is normal, that is very reassuring and further testing would not be needed. So this was the last slide. Acknowledgements and thank you for listening.